Hello, my name is Diane Kohler. I am a cancer genetic counselor at Dana-Farber Cancer Institute, and I'm going to be presenting about cancer genetic counseling today and what we currently consider our best practices for cancer genetic counseling and testing. So I think it's important to start off with talking about what our goals are of cancer genetic counseling. Why are we meeting with people? What are we hoping to accomplish? So I think the primary goal is to evaluate a patient's risk for a hereditary cancer syndrome based on their personal and family history information. We also want to effectively communicate this risk information to the patient to determine an appropriate genetic testing strategy, whether that's we test the person in front of us or we test someone else in the family, or whether testing is appropriate at all. We want to facilitate decision-making for genetic testing to help a patient understand their testing results and the implications for both the patient and their relatives, and to help a patient cope with any emotional responses that might happen when they learn about genetic information. So who do we see for cancer genetic counseling? Our general rule of thumb is that we see young, multiple, and rare cancers. Those are the three big features that we're looking for that might indicate that there's a hereditary cancer syndrome. So by young, I mean any early onset cancer, somebody getting cancer younger than we typically expect based on random general population chance. Multiple cancers, either in one individual or seeing a lot of cancers in a family more than we expect by chance, or rare cancers such as ovarian cancer or pancreatic cancer. More recently, we have been expanding who we see. We've been starting to see more people who might benefit from targeted treatments based on their genetic information, such as PARP inhibitors or immunotherapies. We're starting to see people who have tumor findings that are suggestive of a hereditary risk. As we start to do more and more genomic testing of tumors, this has been a more frequent referral that we've been getting. And we've also been seeing people with a known family history of a hereditary cancer syndrome. As we test more people, we identify more family members who might also benefit from this testing, even if they've never had a cancer diagnosis themselves. So I think it's helpful to start off with talking about who qualifies for genetic testing, because this really sets the stage for why we ask all the questions we do in our medical history and in our family history intake process. Because we're really trying to ask the right questions of the patient to see, do they meet this criteria? And is this something that's appropriate for them? Keep in mind, genetic testing criteria changes all the time, and there's a lot of different recommendations out there. I'm going to be presenting the recommendations from the most current NCCN guidelines, which are typically the guidelines that we follow, but we often still offer testing to people who don't strictly meet this criteria or who maybe meet other criteria or want testing for other reasons. So take this with a grain of salt. Our general overall testing criteria, regardless of cancer type or indication, is to test individuals with any relative with a known pathogenic or likely pathogenic variant in a cancer susceptibility gene, to test individuals who are meeting criteria for testing, but may have had limited testing previously and might be interested in panel-based testing, looking at a larger set of genes. So we see a lot of patients who maybe had BRCA testing in the past that was negative, and they still meet criteria, and now they want a panel-based test to see if there's some other genetic explanation for their personal or family history. We also see people if a mutation was identified on tumor genetic testing that has clinical implications if it's also identified in the germline, and to aid in systemic therapy and surgical decision making. To go more specifically into certain testing criteria based on cancer type. So these are the criteria for high penetrance breast cancer susceptibility genes, which are listed at the top here. So kind of following that earlier theme of young, multiple, rare, for people with a personal history of breast cancer, anyone diagnosed at 45 or younger qualifies for this testing. People who may have been a little older at the age of diagnosis, somewhere between 46 and 50, can still qualify for testing if they maybe don't know a lot of information about their family, or if they personally have another breast cancer diagnosis, or if they have one or more close blood relative with breast, ovarian, or prostate cancer. And for the purposes of these guidelines, close blood relative is defined as any first, second, or third degree relative. And then for patients who are diagnosed over age 50 with a breast cancer, they can still meet criteria if they meet other family history criteria. So for instance, if they have at least one close blood relative who was diagnosed with breast cancer under the age of 50, or had one of these more rare cancer types like a male breast cancer, ovarian cancer, pancreatic, prostate cancer, or if there's a large number of breast cancers in the family, meaning 3 or more total breast cancers, or if there's 2 or more family members with breast or prostate cancer. And we can also offer testing to people diagnosed with breast cancer at any age if they had a triple negative breast cancer, metastatic breast cancer, a lobular breast cancer with a personal or family history of gastric cancer, anybody with male breast cancer, or anyone with a close blood relative with male breast cancer. Sometimes we see people based on family history only, either meaning they themselves do not have a cancer diagnosis, or they have breast cancer, but they still don't meet any of those other criteria. But if they have an affected first or secondary relative who meets this criteria, they can still be an appropriate candidate for testing. We also sometimes will use risk models, basically they're prediction tools to try to estimate someone's lifetime risk for breast cancer for having a BRCA mutation. And if they have over a 5% likelihood of carrying a mutation based on these risk models, it's still perfectly appropriate to test them. And then there's other criteria for other cancer types. So here's the criteria for hereditary ovarian cancer susceptibility genes. Much simpler here, basically anybody with a history of epithelial ovarian cancer, and this includes fallopian tube or peritoneal cancer at any age, qualifies for testing. Or anybody with a first or second degree relative with epithelial ovarian cancer also qualifies for testing. For hereditary pancreatic cancer, very similar. Anybody with a personal history of exocrine pancreatic cancer qualifies for testing, or first degree relatives of people with pancreatic cancer qualify. For prostate cancer, we can see people with certain tumor characteristics of prostate cancer. So anybody with a metastatic prostate cancer is a good candidate for testing, or anybody with certain histology features of their prostate cancer, in particular the intraductal or cribriform type or high or very high risk group prostate cancers. We can also test people by family history. So if they have prostate cancer that doesn't fit criteria based on their tumor characteristics, we can look at their family history. This is very similar to the breast cancer guidelines. We're looking for breast cancers diagnosed under 50, ovarian cancer, pancreatic cancer, or somebody else with a high risk prostate cancer. We can also be testing people just based on their family history. So somebody who has a first degree relative who meets these criteria could also be a good candidate for testing. And for colorectal cancer, we're looking at things like Lynch syndrome and polyposis syndromes. So anybody with a tumor with mismatch repair deficiency diagnosed at any age is a good candidate for this testing because that's highly indicative of Lynch syndrome. We can also look at any individual with colorectal or endometrial cancer who was diagnosed young, meaning under 50, or somebody who's had multiple Lynch-related cancers, somebody who has a first or second degree relative with a Lynch-related cancer diagnosed under 50 years, somebody with over 2 first or second degree relatives with Lynch syndrome-related cancers at any age. We also look for people who've had a large number of colon polyps. So anybody who's had over 20 cumulative adenomatous polyps or over 5 juvenile polyps of the colon, they're good candidates for testing. And there's also some features on here that can go along with APC mutations. And basically anytime those features are seen, testing is appropriate. We sometimes also think about testing just based on family history for this group as well. So very similar to the other criteria. If you have close relatives with early onset colorectal or endometrial cancers, or enough relatives with Lynch syndrome related cancers, you could meet criteria for testing. There's also models to predict the chances of carrying a Lynch syndrome mutation. The primary ones that we use are PREM or MMR-Pro. And if somebody has over a 5% risk based on those models, then it's appropriate to think about testing them. So in thinking about case preparation, so let's say a patient's been referred, they're on your schedule, maybe it's a patient you've never met with before, it's helpful to try to look through some materials ahead of time from the patient's medical records, or try to gather this information ahead of time so you have a bit of a sense of what you might be talking with the patient about, what you should be preparing for. So the main things that we look at are their cancer history. So has the patient had cancer? Have they had it more than once? Try to collect pathology reports when available, so you can see all the details about what type of cancer they had, any pieces of information that might be helpful to determine if they fall into a higher risk group for carrying a gene mutation. So for breast cancer, for instance, we're looking at what age they were diagnosed. We're also looking at their hormone status to see if they had a triple negative breast cancer or a different type of hormone receptor status. It's also helpful to see where they're at in terms of their surgery or treatment, how far out from their diagnosis they are, if they're still currently in treatment or still making surgical decisions. It's helpful to know where in the process they are currently at. It's also helpful to get a sense of their overall cancer screening. So it's helpful to look at their mammogram reports, their colonoscopy reports, any PSA screening that they might be doing to get an overall sense of, are they having routine screening for these cancer types, for breast cancer, colon cancer, prostate cancer? Is there any other type of routine cancer screening that they seem to be doing? And it's also helpful to see if there's any note in any of their charts about family history of cancer, anything you can collect ahead of time. So these are some of the core components of pre-test genetic counseling. So really what we are trying to go through with a patient when we're meeting with them prior to doing any kind of genetic testing. So we always start out with contracting, and this is basically when we have a chance to build some rapport with the patients, get a sense of if they have any understanding of why they were referred to speak with genetics, how they've been feeling leading up to the appointment, if there's any major questions, concerns, topics that they want to make sure we address throughout the appointment. And this is a time for us to set an agenda together to help them understand this is what we're going to be going through. Is that okay with you? And come up with a plan together. Then we will typically move into medical history collection, anything you couldn't find during case prep. You want to fill in any of those gaps during the medical history intake. You want to collect family history information. Usually we're taking a pedigree during that time, trying to assess the family history of cancer. And then once we have all that information, we can do our risk assessment. We can say, based on what we're seeing from this medical history and this family history, what do I think this patient's risk is for carrying one of these gene mutations? And what kind of testing might be appropriate based on that? And then we spend a lot of time on patient education, really going through with the patient what we think their risk is, what genetic testing entails, what that would mean for them, and then help guide them through informed consent for genetic testing, help them decide if that's something they're interested in, and preparation for results disclosure. So if they decide to pursue genetic testing, we want to make sure that we've come up with a plan with them for how these results will be delivered to them. So just to go through the medical history, these are typically the core pieces of information that we are trying to collect for most patients. So like I said, for cancer history, we're trying to get a sense of the type of cancer, any relevant characteristics of the cancer, like is it metastatic? Is there a certain type of pathology that we're looking at? What are the hormone receptor status? What age were they diagnosed and what kind of surgery and treatment have they had? It's often also helpful to get a sense of the patient's surgical history, really to see, what organs does this patient have or not have? What are they at risk for cancer-wise? Current cancer screenings for things like breast cancer, colorectal cancer, prostate cancer. These are things that you can ask about during the medical history portion of the session. And usually we're trying to see what type of screening are they getting, how often are they getting it, and what are the most recent results. So for instance, we might ask somebody if they're getting colon cancer screening with colonoscopies. We'd want to know, are you getting it every 5 years or every 10 years? When was your most recent one? And have you ever had any polyps found on your colonoscopy? We also like to ask about hormonal history because this can be a helpful tool specifically for making a breast cancer risk assessment. So a lot of these questions are things that we can then plug into risk models to get a better sense of what a patient's lifetime risk for breast or ovarian cancer might be. So we like to ask about their age at first period, age of menopause, how many pregnancies they've had, how many live births they've had, how old they were at the first live birth, how long they took birth control pills for, how long they took hormone replacement therapy, and if they've ever had their uterus or ovaries removed. Sometimes it's helpful to use an intake form for the medical history. A lot of genetic counselors will utilize intake forms just to help guide you through all these questions, make sure you're not forgetting anything, make sure you have it written down in an easy way. So this would just be an example of what an intake form might look like to help guide you through all those questions to collect. So the next step in the process is typically to collect the family history information. So we like to collect a 3-generation pedigree. So this means we are asking about children, grandchildren, siblings, parents, aunts and uncles, cousins, and grandparents. So you can see on the screen here an example of what a completed 3-generation pedigree might look like for a hypothetical patient. You also want to ask for each of these individuals either their current age or their age at death. And you want to ask about their cancer history, meaning what type of cancer they had and the age of onset. So these are the very basic questions to ask. So you can see on this pedigree here, we have the proband is marked with this arrow. Looks like she's a 49-year-old woman who was diagnosed with breast cancer recently at age 49. She has a paternal aunt with breast cancer at 72 who passed away at 78. She's got a maternal uncle who had prostate cancer at 68, is still living at 72. And she has a maternal cousin who passed away at 55 after 2 years with ovarian cancer. So then once we have all of this pedigree information, you want to do a risk assessment. So you want to basically analyze this pedigree and see, is this a person who qualifies for testing? And what do I think that their risk is for having a gene mutation? Are they in a high risk category, maybe a moderate risk, maybe a low risk for having a gene mutation? So these are the overall kind of general questions you might ask when thinking through your risk assessment. So the first is, are more people than average in the family diagnosed with cancer? Are we seeing like everyone getting diagnosed or less people than typical diagnosed? I would say on this family looks like a pretty average amount of cancer, maybe a little higher than average, but not striking in terms of the number of people affected with cancer. Then we want to look at, was anyone diagnosed with an early onset cancer? And I would say for this patient here with her breast cancer at 49, that is considered a pretty early onset breast cancer. So I would say yes for early onset there. The other breast cancer, not considered early onset at 72, a prostate cancer at 68, not particularly early onset. We're also looking at, was anyone diagnosed with a rare cancer like ovarian or pancreatic cancer? And you can see in this family, the answer is yes, there was a cousin diagnosed with an ovarian cancer. We want to look at, do any cancers have features suggestive of a hereditary cause, such as a triple negative breast cancer or a metastatic prostate cancer? And that's not something that's noted on this family tree. We're looking at, are multiple people with the same or related cancers being diagnosed? So you can see on this side of the family, there are 2 cases of breast cancer, if you include the patient and her aunt on the dad's side of the family. And then on the mom's side of the family too, we can see prostate and ovarian cancer, which can both be related to breast cancer with things like a BRCA mutation. So there are related cancers in the family. We also want to look at who's the best person in the family to test. In this case, this proband is a good person to test based on her age and her personal history of breast cancer. If her sister had been the one who came into the appointment, we'd probably say, you know, maybe we don't need to test you if we can get your sister with breast cancer tested first. So sometimes risk models can be helpful to give you a better estimate of what someone's risk for carrying a mutation might be or what their cancer risk may be. So I mentioned these a little bit earlier, but this just lists out some of the most common risk models that are used and some of the most well-validated risk models. So one is BRCA Pro. This can show the probability that an individual carries a germline mutation in BRCA1 or 2 based on their personal and family history of breast and ovarian cancer. Tyrer-Cuzick is another useful tool to try to generate the risk for a BRCA1 or 2 mutation. And it's also helpful in calculating breast cancer risk. So it generates a 10-year and lifetime breast cancer risk based on personal and family history and certain hormonal features. CanRisk can calculate the lifetime risk of developing breast or ovarian cancer and the likelihood of carrying a wider variety of mutations, such as BRCA1 and 2, PALB2, ATM, and CHEK2. The Gale model does not predict the risk for carrying gene mutations, but it can be useful for calculating someone's 5-year and lifetime breast cancer risk. And then PREM and MMR Pro are both tools that can calculate the probability that an individual has Lynch syndrome. So then we typically move into patient education after we've completed our risk assessment and think we have a sense of what a patient's risk for a hereditary syndrome might be. It's often helpful to start off with a basic discussion of hereditary versus familial versus sporadic cancers, helping people have some context for how rare hereditary cancers are, and how sometimes we can see clustering of cancer in a family, and it doesn't necessarily mean it's hereditary because we know our environment and other factors can also play a role. We also often talk about some of the basics of genetics in general and cancer genetics, explaining basically what our genes are, what these cancer genes are doing when they're working normally, what it means to have a mutation or a change in one of these genes. We'll often walk through their individualized risk for a hereditary cancer syndrome, help kind of walk through that risk assessment with the patient, help them understand what we're seeing or not seeing in the family that might make us more or less suspicious that they might have one of these gene mutations. You want to discuss genetic testing options and logistics, help patients understand what it really means to get genetic testing, how they do it, how they get the results. You want to discuss possible test results, which we'll go through a little more later. You want to discuss medical management. What does it mean if we get each of these different outcomes of the testing? And you also want to discuss inheritance and the implications for the family. And ideally, all of this is done as more of a discussion rather than a lecture, doing your best to engage with the patient the whole time, give them plenty of opportunities to ask questions, asking them to maybe summarize their understanding of what you've said to make sure that they're really understanding everything as you go through it. So oftentimes visual aids are very helpful as a tool for helping guide through this education portion, and to just help patients have another way to visualize this information rather than just hearing it. So this is an example of a visual aid you might use to describe hereditary, familial, and sporadic cancers, really showing that the majority of cancers are sporadic due to just lifestyle, environment, or chance. A smaller portion, about 15%, are familial, meaning they're due to some combination of genetic and environmental factors, and only 5 to 10% are hereditary, meaning they're due to one of these inherited mutations in a cancer risk gene. This is another commonly used style of visual aid, basically showing, where our genes come from in the cell, showing that in our cells, we have our chromosomes, which are basically packaged up pieces of DNA, which make up our genes and is made up of nucleotides. This is a visual aid to help show different types of inheritance. Typically, in the cancer genetic setting, we're mostly talking about autosomal dominant inheritance. So a visual like this can help show how this can be passed on through a family and the importance of cascade testing. So the genetic testing itself typically can be done with a blood or saliva specimen most of the time. You want to make sure you're sending it to a lab that's doing comprehensive testing, including full sequencing and deletion duplication analysis. Typically, we are recommending panel-based testing that covers multiple actionable cancer types for all patients, regardless of their indication. So even if we're seeing somebody who really just has breast cancer in their family, we're typically including colon cancer genes in their testing because it's still an actionable cancer type. It's something that we have reliable screening for. So our panels that we order typically include at least 30 genes associated with breast, gynecologic, prostate, and colon cancer risk. Some patients understandably do prefer smaller or more targeted panels. And we also know that analyzing more genes can sometimes increase the chance of us finding incidental findings that are totally unrelated to the reason the patient presented, or uncertain findings. So some patients prefer to avoid that and stick with maybe a smaller, more targeted test focus specifically on what we're seeing in them and their family. So for the possible outcomes of testing, there are 3 types of results we get from genetic testing. One is a positive result. That is when a pathogenic or likely pathogenic variant associated with an increased risk for cancer is identified. There are different levels of risk that come along with the positive results. Some genes are considered fairly high risk genes. Other genes are in a more moderate or low risk category. So there can be quite significant differences and recommendations that come out of a positive test result. We can also see a variant of uncertain significance. This is a very, very common result, especially with panel-based testing where we're looking at a broader set of genes. And this means a variant is identified, but it's unclear whether this variant is associated with an increased cancer risk. Most of these are eventually reclassified as negative results, and they are not considered clinically actionable. So we typically don't test family members. We don't act on these changes because most of them are just parts of what make us different, not things that are harmful to us. The most common outcome of genetic testing is a negative result, meaning no variants or only benign or likely benign variants are identified. So to help patients through decision making, you really want to make sure that you're presenting them with all the pros and cons of testing. Some people come in knowing right away, oh, I know I want this information. I know I want testing. I don't really need to hear all of this. Other people get really torn. They don't really know what all the pros and cons are, and they have trouble making that decision. So this is just, certainly a shorter list than the full possible list of pros and cons, but some of the pros of testing are that it can inform surgery or systemic treatment for somebody with a cancer diagnosis. It can help end uncertainty about one's gene status. Some people come in with a really strong family history of cancer and they come in feeling very certain that they have a gene mutation, and they just kind of want to know. They just want to know what their status is so they know what kind of risk they have and can use that moving forward. This can lead to more tailored cancer screening and prevention, and this can also clarify the cancer risks for other family members. I know we hear this a lot from parents that they want to protect their children, even if they have a gene mutation. Obviously, that's terrible news that they don't want to have to share with their children, but it at least helps give them some more context. It helps their children have the tools to maybe be more proactive and get access to more screening and preventative options. Some of the cons are that genetic testing can increase cancer worry and sadness. If we find a gene mutation associated with a high risk for cancer, and you're telling that to somebody who already has cancer, they can get really anxious about getting another cancer in the future. Or for somebody who's never had a cancer, it can be terrifying to have to think about your risk for cancer being higher than the average person's. It can also strain family relationships. We do hear a lot from our patients with mutations that it can be really challenging to be the one who has to share this information with your family members, especially while you personally are also learning to cope with this information. So especially if you already had strained relationships, this can potentially further strain those relationships. We also know that sometimes there's questionable medical benefit. Sometimes we find a change in a gene that we don't have the best screening or management options for. So sometimes it's increasing this worry and we don't necessarily have the best tools available to be preventative about that risk. So sometimes it's just helpful to present things like this to patients if they're struggling with that decision making to help them decide, do they on a personal level think the pros outweigh the cons, or do they think, in light of these cons, testing's maybe not worth it for them if it's something that's going to keep them up at night and not something that they think would be overall beneficial to them. So for informed consent, this is very important for genetic testing. You want to make sure that any client who you're meeting with, who you are consenting to testing, can basically answer these questions at the end of your session. I feel like I've done a good job if a patient could answer all these questions for me and provide that informed consent for testing. So they should be able to say, how is the testing performed? What are the possible results of this test? What are the risks and limitations of this test? How will I learn my results? Who can I speak with about my test and my results? And how will the lab use and protect my data? We know that some genetic testing labs do use data for internal research purposes, and it's just important that patients understand how their data could be used because this is personal health information. So for results disclosure, it's important to come up with a plan during that pre-test appointment for results disclosure. So you want to make sure you have a clear plan with your patient about the mode of disclosure, whether that's going to be in person or over the phone. Different centers take different approaches to this. We tend to do most of our results disclosures over the phone, unless a patient has a strong preference for meeting in person to review their results. Other centers see all of their patients in person to review results. There's no right or wrong answer here. It's whatever kind of feels most comfortable to you and to your patients. And then for the disclosure itself, these are some tips for kind of how to go about that results disclosure. So one, disclose the results early in the conversation. So don't make the patient wait for it. Typically, they're already going to be feeling anxious about their result. So it's more helpful to just kind of get it out there so the patient can hear it and start processing it. Use direct and clear language. Sometimes on these lab reports, it's very scientific language, and it's helpful to make sure that you're kind of using the clearest language possible for the patient, especially if you're delivering bad news or what a patient might interpret as bad news, because we know that even for people who are very informed on this topic, very savvy, once you've just learned harmful information or information that is going to upset you, your level of comprehension can go down. So it's helpful to kind of make sure everything's as clear and simple as possible, but also accurate. You don't want to be sugarcoating what's going on. You want to allow clients time to react. I know, especially on the phone, sometimes silence can be uncomfortable. Our natural reaction is to kind of fill all the space with words as much as possible, but it's really helpful after you've delivered a result to just kind of take a pause, let the patient sit with it a little bit, process it a little bit. You want to be as empathetic and professional as possible. Let clients set the remaining agenda. Some people, when we disclose results on the phone, just don't really want to talk to us anymore, just want to process it themselves until they come in for their follow-up visit. Other people really want to know all the details. They want to know, what does this mean? What are my next steps? That's what's going to help them process. So try your best to be client directed, let them kind of lead the conversation for whatever's going to be most helpful for them. And then it's important to talk about what happens next. Are they coming back in for a follow-up visit? Is there anything else that needs to be done in the meantime? Just come up with some kind of plan so you're not just leaving them hanging. So for negative or VUS results, these are some of the possible explanations for why you might be getting a negative result. One, there could be mutations in other genes that were analyzed by this test. Depending on the size of test you ordered, it's possible that you might recommend some additional expanded testing to try to be a little bit more comprehensive if you feel like there should have been something found. There could be a mutation in the family, but the person tested didn't necessarily inherit it. So in that case, you might want to consider testing a more appropriate family member if they're available for testing and willing. There is a small chance a mutation could have been missed due to technology limitations. And it's also possible, and this is probably the most likely outcome of negative results, is that the cancer in the family may not be due to a single inherited gene mutation, but due to a combination of genetic and environmental factors. We know that clustering of cancer can be seen in a family by chance or due to shared environments or similar lifestyles. So in the context of negative or VUS results, a patient may still benefit from increased cancer screening based on their own history or their family history. So this is also where those risk models can come in handy, particularly for breast cancer risk. So for breast cancer risk, you can use things like Tyrer-Cuzick to determine whether a patient may benefit from extra breast cancer screening in light of other risk factors, non-genetic risk factors. Also, if there's a family history of colon cancer, a patient may benefit from starting their colonoscopies at a younger age or doing them more frequently. So there still can be some tailored cancer screening guidelines that come out of a genetics visit, even with negative or VUS results. Just a few extra notes on VUS results. One thing that we routinely do when we encounter a VUS result is to look it up in ClinVar. So this is a publicly available database where labs basically report their results, and you can see if other testing labs might report it differently. So you might have a VUS result, but maybe a different clinical testing lab calls it benign, in which case you can be even more reassuring about that result. But in cases where maybe a different lab calls it pathogenic, then you might want to look a little bit more into it, and you might consider the option of treating that uncertain result as if it were a positive if there's enough convincing evidence from other reputable labs. Most VUS results are eventually downgraded to benign or likely benign variants. So Most genetic testing labs do have some system for keeping track of their VUS results and issuing new reports over time as they reclassify them. So, most labs that you should be using should have some method for this. And basically over time, as they test more people, get more data, if they can eventually reclassify a variant, they should be issuing a new report to you that you can then share with the patient. It's generally not recommended to test family members specifically for a VUS or to alter medical management based solely on a VUS. It's also important to make sure you have up-to-date contact information for your patients who have VUSs. That way you can reach them in the future if you ever get one of these reclassifications. So for positive results, often before you speak with the patient about it, it's helpful to review the risks associated with the mutation identified. So typically on the lab report, it should list the cancer associations that are known to go along with that particular variant. And there should also be some references included there that you can reference if you wanted to look at the primary literature about that gene or that variant. NCCN guidelines and gene reviews are other good sources of risk information and references that we refer to all the time, just to make sure that we're giving the most up-to-date and accurate information. It's also helpful to review the medical management guidelines for mutation carriers so you know what types of things might be recommended for the patient based on their results. With the patients, you'd want to discuss options for increased surveillance or risk reduction. You also want to make sure you have providers that you can refer to. So, if you've identified a mutation in a breast cancer risk gene, you want to make sure that you can refer that patient to a place where they can get the appropriate breast cancer screening. And you also want to make sure you're discussing cascade testing and who else in the family should be tested. So this is just a screenshot of the most current NCCN guidelines with an example of how they present their risk information. So this is part of a much larger table that basically goes gene by gene, breaks down the risk for breast cancer, ovarian cancer, other types of cancers. It gives you the relative risk, how much evidence there is for it, how strong that evidence is. And there's also a table on management, what to do when you find these variants. So this is typically what we follow when discussing risk with patients and making medical management recommendations. So this is a general overview of what medical management could typically look like for genes that fall into certain categories. So for instance, for the high-risk breast cancer genes, so things like BRCA1 and 2 and PALB2, patients are usually presented with two options. One is increased surveillance. Usually this is annual mammograms and annual breast MRIs starting at a younger age than we would typically start breast cancer screening. The other option is for risk reducing surgery. So for some women, going in every 6 months for imaging is really challenging, or for some people, breast MRIs aren't as easily accessible as other people. So they might be more likely to opt for surgery with risk reducing bilateral mastectomies to try to reduce that cancer risk as much as possible. For the moderate risk breast cancer genes, we don't as often offer patients the risk reducing surgery, but this is something that some people are choosing to do even with a moderate risk breast cancer gene. But typically it's increased surveillance that is recommended for people with these mutations. This is typically like ATM and CHEK2 gene mutations. And it's usually with annual mammograms and annual breast MRIs, sometimes starting at a younger age than we typically would. For ovarian cancer genes, really any genetic finding that indicates a higher risk for ovarian cancer, typically risk reducing surgery is recommended with a risk reducing BSO. And this is just because with ovarian cancer, we don't really have reliable screening. We don't have a great way of detecting ovarian cancers at early stages when it's actionable. So we know that the best way to have the best outcomes for patients is to recommend surgical risk reduction. For prostate cancer, we found an increased risk for prostate cancer based on the genetic testing. Typically, it's surveillance. We might start doing annual PSA and DRE at an earlier age compared to the average person, but it's typically just screening that is recommended. For pancreatic cancer susceptibility genes, similarly, surveillance can be recommended. This is often family history dependent. So sometimes even if somebody has a mutation in one of these genes, if they don't necessarily have a family history of pancreatic cancer, then screening may not be recommended. And for colon cancer susceptibility genes, typically doing increased surveillance. So we might increase the frequency of colonoscopy screening, and we might start at a younger age than we typically do. So first, surgical and treatment implications. So this is really for patients who have a current cancer diagnosis and are found to have an inherited gene mutation. So some of the surgical implications could be specifically for breast cancer patients is where we most often see this. So for instance, a breast cancer patient who's found to have a mutation in a high-risk breast cancer gene may choose to have bilateral mastectomies rather than a breast conserving surgery to help reduce the risk of a second primary breast cancer later on in life. So we are often seeing our high-risk breast cancer patients pretty early on, pretty shortly after they're diagnosed, because we really want to get them their testing before their surgery if we can, because we know that these results can have a big impact on what type of surgery they may elect to pursue. Similar for prostate cancer. So if a patient's found to have maybe an early stage prostate cancer, but then we do the testing and find that he carries a high risk prostate cancer gene, he may elect to pursue a prostatectomy rather than active surveillance as part of his surgical course. For treatment implications, so we know that BRCA1 and 2 can have implications for targeted treatments. So if we find one of those mutations, a patient may be eligible for things like PARP inhibitors, and a patient with Lynch syndrome may be eligible for treatment with immunotherapy. So there can be implications on more systemic therapies as well. So for cascade testing, we know that most hereditary cancer syndromes are inherited in an autosomal dominant fashion. So this means that all first-degree relatives of a patient with an inherited gene mutation have a 50% chance to also carry that mutation. So it's important to encourage patients to share their genetic testing results with their family members, especially their first-degree relatives. So that means their children, their siblings, their parents. Most of these genes are considered adult onset. Very few of them have childhood cancer risks associated with them. So we typically like to wait until people are of adult age before we think about doing testing for them. We don't like to test children or minors for these conditions unless it's going to impact their health at that age. We know that other family members like aunts, uncles, cousins are also at risk to carry the mutation, so it may be appropriate to share this information with them as well. And if somebody in the family tests negative for a known mutation in the family, then we can consider them a true negative. So if there's a striking family history of breast cancer and we find a BRCA mutation and somebody tests negative for it, that can be really reassuring about their risk, because then we can put them back down to average population level risk for breast cancer. And we know that once they test negative, they can't pass on what they don't have. It cannot skip a generation. So they can be considered a true negative for that variant. It's also important to note that men and women can carry all of these gene mutations and can pass them on to their sons and daughters. I know there are some people who have a lot of misunderstandings about this. They don't think that men can carry BRCA gene mutations or it doesn't affect them, and that's just not true, unfortunately. So we know that it's important to look at both sides of a family, share this information with everyone in the family, regardless of gender. Patient letters can be a helpful tool for communicating this information with patients. That way they don't just have to rely on remembering everything you've discussed with them during results disclosure and follow-up. So we often provide a lot of written information for patients as well. So typically we give patients a summary letter that includes a summary of their genetic testing results, what they mean for the patient, medical management recommendations, and recommendations for family members in simple, clear language. And we also will typically include a copy of their test report and their family tree along with that. We often also write something we call family letters, which are basically letters designed for them to share with their family members to help encourage them to pursue testing if they're interested and just help with that communication with family members because we know it can be a big burden to have to share this information and it can be really complicated information to share. So these family letters are really designed to facilitate that process. So another important thing to note are psychosocial responses. So we can see a variety of different emotions and reactions that can come along with news of a genetic testing result, especially a positive result. So this is just a list of some of the normal and typical responses that we can see either while waiting for results or after receiving results. So it's important to keep these in mind, understand that they're normal, and be prepared to address these types of emotions that might come from patients. So some patients might feel angry that they have this gene mutation. They feel like it's not fair that this happened to them. A lot of patients will feel significant anxiety, especially when thinking about a future cancer risk. People can feel a fear of disfigurement or disability, what this can really mean if they do develop a cancer from one of these gene mutations. Fear of dying, really common with these when talking about inherited gene mutations. We can also see things like grief, guilt and shame, especially among parents who may have passed on one of these gene mutations to their children. You know, I always like to frame it as we can't control what we pass on, but it's really hard for parents sometimes to process the guilt of passing on a risk for cancer to a child. There can be a sense of a loss of control, especially about their health. Some people have more positive emotions about it. It might give them more a sense of resiliency or pleasant emotions. People can feel sadness. The sense of identity can be impacted by it. Some people, when they learn they have something like a BRCA mutation, it kind of becomes a core part of their identity. It becomes something that's very kind of important to them. It makes up a lot of who they are moving forward. We can also see a sense of isolation. We know that these gene mutations are rare. Oftentimes, people have never heard about the gene that we're diagnosing them with the mutation in, and they can feel very alone and isolated and feel like nobody else is going through what they're going through. And we can also see significant stress and trauma. So these are all normal responses to this information that, if you're providing genetic counseling, you need to be prepared to address. So to help do a psychosocial assessment to try to get at what is a patient feeling, to what extent are they feeling it, these are some of the core things to ask about. One is just current emotional well-being. How are they doing overall? How are they doing since learning about their test results? Their mental health history is helpful if they've ever been diagnosed with any kind of mental health problems in the past, if they've ever had therapy or are currently in therapy. It's helpful to ask them directly about their emotional reactions, how they've been reacting to their results, if they've had any kind of big emotions come from it. It's helpful to talk about timing. Are they thinking about this all the time? Is it keeping them up at night? Or is it something that they're only really thinking about when they have to, when they're in a medical appointment? And you can also ask about coping strategies. So, what have they been doing to try to process these emotions? Have they been employing kind of what we consider healthy coping strategies, or are they maybe employing unhealthy coping strategies? So, this can all be kind of things to ask about to get a sense of how is the patient doing and how much do you need to intervene? How much support do you need to provide? So for psychosocial counseling, this is obviously a very kind of basic overview. We are not meant to be, very in-depth mental health providers, but it can be helpful to do these things and decide if a patient might benefit from more targeted mental health care from a mental health provider. So it's important, of course, to always convey empathy, stay attuned to the patient's verbal and nonverbal cues, employ active listening, make sure you're really hearing what the patient's saying, reflecting on what they're saying, validating how they're feeling. Ask rather than assume. If you see someone crying, you can probably assume while they're crying, but it's helpful to ask them and get them to elaborate on what's making them feel so upset. Ascertain the rationale behind questions and reactions. If they're asking you certain questions, it's helpful to see, well, why do you ask that? Is there something that's bothering you that's making you feel anxious about that question? Allow clients to express their emotions. I know sometimes patients don't really know what to expect in a genetic counseling visit. They don't know if it's a space where it's okay for them to be emotional and express their emotions. So it's important to give them that space and make it known that it's okay if they're feeling emotional and it's okay to express those emotions in here. You want to respect their boundaries. So if somebody doesn't really want to open up to you and doesn't really want to go there, that's completely okay. You want to monitor their reactions. You want to have strategies to deal with resistant clients. You want to make sure you're remaining professional, and you want to be able to help the client with any decisions and actions. So for post-test counseling and follow-up, these are the main things that you want to make sure you're conveying to the patient that they understand if you're having a follow-up or post-test counseling visit with the patient. So you want to make sure they understand the implication of the result for themselves and their medical management options, what this means for next steps for them, whether it's for their own cancer management or for future cancer prevention. You want to make sure they understand the implications of the result to their family. You want to have a plan for follow-up interactions. You want to help them adjust to the result. You want to review the genetics, make sure they understand kind of everything about the result, what it means, and you want to make sure you have the appropriate referrals to specialists that are needed based on that result. So that is all that I have. So thank you so much for your time. I included my email address on here. If you had any questions, feel free to reach me by email. Thank you so much.